Good afternoon, everyone. I would like to start by thanking Drs. Regina Hooley and Bob Goodman for having me over at Yale University today. It is a pleasure and a privilege to present to you on the imaging opportunities around the Cancer Moonshots platforms at MD Anderson Cancer Center. By applying today's knowledge and game-changing technologies, MD Anderson's Moonshots program is poised to dramatically accelerate improved survival in the next 5 to 10 years beyond the 1 to 2% annual declines in cancer mortality that we've seen in the past decade. This represents a goal-oriented, multidisciplinary effort to harness the available knowledge and new disruptive technologies aimed at reducing cancer mortality through prevention, early detection, and curative treatments. The current national and global network of the MD Anderson Cancer Moonshot platforms extends beyond North America into South America, as well as into Europe and parts of Asia. A total of 32 sister institutions in 23 countries are currently affiliated with the MD Anderson Sister Network platform. This is based on the background that the number of cancer patients from 2010 to 2030 is expected to increase by 45%. An estimated 100 million people worldwide will be expected to lose their lives to cancer in this decade alone. The disease's devastation to humanity now exceeds that of cardiovascular disease, tuberculosis, HIV, and malaria combined. The current disease sites that the Anderson Moonshots platforms is focusing on is listed on this slide, and the 4 cancers highlighted in yellow are lung cancer, melanoma, breast cancer, and ovarian cancer. The professional platforms that have been created and developed over the last few years to allow for integration into translation of these specific moonshot platforms include cancer prevention and control, immunotherapy translation, proteomics, and a translational research accelerator. Moving on to the lung cancer initiatives as the first topic of interest. This was spawned slightly after 2011, following the results from the National Lung Cancer Screening Trial, which demonstrated a 20% relative decrease in mortality for patients at risk of developing lung cancer when compared with radiographic surveillance. With the B rating recommendation issued by the U.S. Preventative Services Task Force, a comprehensive lung cancer screening program was established at Anderson with the following goals: to mandate shared decision-making, smoking cessation, and the aim of decreasing the high 96% false positive rate of lung cancer diagnosis in subjects with suspicious pulmonary nodules. In an effort to support this goal of reducing false positives, a protocol 2013-0609 was initiated, which represents a biospecimen banking and biomarker validation for lung cancer early detection project. The goal was to accrue 15,000 patients, both current and former smokers, who would undergo the following tests: low-dose CT screening, spirometry, biospecimen collection, and a prospective follow-up for a minimum of 5 years for each participant on study in order to establish a lung cancer early detection reference library set, and with the ultimate goal of evaluating lung cancer early detection biomarkers. So here you see a graphic of the actual project, which illustrates the combination of imaging together with collection of biomarkers. And as of last week, a total of 3,000 patients have been accrued over multiple sites, both nationally at Anderson and also internationally, primarily in China. And the goal will be to accrue at additional sites in the United States as well as in Madrid, Spain. What is the imaging companion to this aspect of the moonshot? CT texture analysis is something that we are working on aggressively, which represents an imaging processing method that can be routinely applied to the CT images that you will see on the next slide. And the goal is to provide quantitative information that cannot be readily identified, as you see on this triplanar scan showing a left lung mass, pre and post segmentation. The goal then is to be able to extract information from this quantitative data and mine it ultimately together with other areas in the big data domain, including all different aspects of the omics data bank. So this brings us on to the Quantitative Image Analysis Core, which is a platform that we initiated 2 years ago in diagnostic imaging and that is institutionally supported with the purpose of providing centralized, standardized imaging metrics both for clinical work and for research protocols. The paradigm here is that the imaging analytics will be integrated ultimately with big data for future mining and retrieval initiatives. This slide shows the workflow for this process. So as images are being collected on the scanners and sent to the clinical packs where the radiologists generally would generate the clinical report, any patient who's on a research protocol will have a user request initiated, and in tandem, the images will be sent to a parallel pack system where they are de-identified and stored as both raw and DICAM formats. And we have an imaging research specialist or a technical specialist who will be marking out the lesions of interest for measurement. And at that time, a report for KAYAK will be generated in tandem to be overviewed and vetted by the reporting radiologist so that this will be available to the clinic in real time. So the workflow is that KAYAK will receive a service request. The IRS will immediately begin to identify the lesions of interest, compare with baseline studies, and perform the tumorimetric measurements, and the radiologist then logs on and verifies the report, after which the KAYAK report will be generated. This is automatically fed into KAYAK into EPIC as a clinical report that is presented in a tabular format. And to the left is the patient's baseline measurements, and the subsequent measurements will be following to the right. There is opportunity to view these results in graphic form, and at the click of a button, the actual images representing that specific time point in measurement is also available for viewing by the clinician. So here we see images at baseline, follow-up 1 and follow-up 2 that are accessible in the clinic using the KAYAK platform on EPIC. The menu of services include quantitative image analytics that are listed on this top half of the slide, with volumetrics and advanced analytics in the pipeline that are being developed right now. And ultimately, the advanced image analytic platform would include correlation with genomic markers to support clinical trials, and the one that's about to kick off is the SU2C trial for lung cancer. The organizational oversight is provided by myself and my colleague Dave Puniker-Worms, with multiple co-directors in the subspecialties, including chest radiology, Brett Carter, abdominal radiology, Priya Bosley, whom some of you may know, and Rivka Colin in neuroradiology. There is also support from the technical liaisons as well as strategic business development, and we talked about the imaging research specialists. To date, after a 24-month period, we have a total of 301 active protocols from 11 collaborating departments, and the number of measurements have increased, and I don't think it's showing on this slide, but it's about 3,000 measurements over the 24-month period. There is also a charge system for this service that is assigned for every research protocol that requests the KAYAK service. And the purpose of separating this into technical and pro fees is that the technical fee allows for self-sustainability of the administrative function of this service, while the pro fees go to the radiologists who participate in these protocols as an incentive, not only for them to be able to collect funds to use for their own R&D purposes, but also as an incentive for them to get engaged within the multidisciplinary environment and create networks for their future research interests. The next area will be to talk a little bit on the Moonshots with respect to the immunotherapy platform. And we are well aware that for patients with advanced disease that recur or relapse, that targeted therapy has shown success in increasing survival, but for a limited time frame. The success usually falls off in the 3rd or 4th year of treatment. However, with the recent interest in immunotherapy combined strategies, we see from the purple line that when combined with targeted therapies, a small percentage of these patients who relapse are able to have extended remission beyond 10 years. So this has sparked a huge amount of interest both on the clinical, the translational, and also on the imaging platforms as to how we can best maximize these game-changing paradigms. Everybody's familiar with the IR RECIST, and basically Jen Wago from the melanoma team has been the lead on several immunotherapy platform protocols. I've just shown the slide here where the imaging group has been able to begin a small collaboration with Jen. And essentially, it's a comprehensive integrated serial analysis where patients with metastatic disease will be profiled, and then the non-responders will be identified, profiled again, and then treated again with a PD-1 agent, and then goes on and on and on in an attempt to create a more personalized medicine approach. So in terms of melanoma, moonshot, and imaging, the intratumoral heterogeneity seen in these metastatic lesions is reflected in the areas of high cell density, necrosis, hemorrhage, and myxoid change, and has been recognized that this high intratumoral heterogeneity is associated with high tumor grades and then poorer outcomes. So in terms of evaluating the treatment response, we can use a myriad of these criteria listed on the top, but we were very interested in seeing what CT textural analysis could do in terms of predicting pathologic response or differential response. This is early data with a very small group of patients, 7 patients with advanced melanoma who had biopsy-proven metastatic disease treated with various therapies. So this is end of line and 3rd phase, 4th line treatment. The texture features from the metastatic lesions were extracted from the biopsy-proven targets, and baseline as well as follow-up CT scans were performed. Some of them had PET CTs, and the texture analysis was then performed on these lesions. And as shown, you will see on the next slide that there were certain features that were panning out in this very small group that would reflect intratumoral heterogeneity, key of which would be entropy. So the lesions, as you see, would be multiple metastatic lesions from the same patient. To your left, you see the 1st, 2nd, and 3rd metastatic lesion in the same patient, and also seen at different time points, both at baseline and 25 weeks after targeted therapy, as well as baseline and 11 weeks after immunotherapy. So the textural analysis early data suggests that entropy is more a marker of heterogeneity and poor prognostic outcome, whilst homogeneity tends to be more associated with the good responders. So a lot of ongoing work is still being pursued along those lines. What about tumor heterogeneity, as we just alluded to? How does it affect a patient's response to any form of treatment? And the thinking is that while we focused a lot on the cancer genome, what about the inherited genome, the environment, the microenvironment, as well as the parameter of time? So this brings me to a topic that's closer to my heart. I'm by business training a breast imager, and we have a moonshot that's focused on triple-negative breast cancer that represents a multidisciplinary effort, and the theme we chose for this was Artemis, which is a randomized TNBC trial that aims to confirm molecular profiling that will improve survival. So the collaborative groups are imaging, the clinicians manning the clinical trial component, molecular profiling, the experimental radiation oncologists working on PDX models and also metabolomics under cancer systems. So the early publications 3 to 4 years ago have demonstrated that quantification of residual cancer burden is directly correlated with outcomes. As we see here, both PCR and RCB1 patients tend to do significantly better in the green box compared to those with extensive residual disease after neoadjuvant treatment. Furthermore, the follow-up work using these genomic predictors showed that they were successful in terms of predicting response and survival with a PPV at the level of 83%. We are now familiar with the fact that triple-negative breast cancer is not one disease, but is made up of between 7 to 11 subtypes, depending on which paper you have become familiar with. And I show on this slide the 6 major subtypes that have been of interest to our group: the basal-likes, the immune cell process groups, the cell motility groups, and more of the metaplastics, as well as the androgen receptor positive groups at the bottom. Interestingly, the subtypes of triple-negative breast cancers do not predict response to neoadjuvant chemotherapy, and this was borne out by the PAM50 study that did not predict PCR from neoadjuvant chemotherapy, including the addition of carboplatin. We know, however, that targeted therapy impacts chemosensitivity, as you see, that after targeted therapy is administered, the PCR rate from red to blue increases significantly. So the concept of this Artemis trial was to start out with pre-treatment biopsies to generate molecular diagnosis that would guide treatment and decision making, after which the patient would undergo routine chemotherapy, and a decision would then be made to either move on to targeted therapy for non-responders. So the non-responders would be defined by their molecular diagnostics as well as an imaging component. And the goal here is to improve the proportion or segment of PCR patients from 50% to 64%, so a 14% delta. The chemoinsensitive groups would be estimated to fall in these following 4 categories based on prediction and interim imaging, and then would be offered an adaptive serial trial using targeted agents listed in the bottom right-hand corner. So moving on from the first slide, we see that the pre-treatment imaging and biopsy plays a significant role both at baseline, at the mid-treatment segment, and also right before surgery. The criteria for the imaging component that we used was that non-responders would have less than an 80% overall reduction in the tumor volume. So the protocol listed here is assessment of tumor response to neoadjuvant chemotherapy in women with invasive breast cancer using the technetium-99m sestamibi molecular breast imaging, which is a tool, a functional tool that we are hoping to use to interrogate these tumors and find a means of quantitation for tumor response. So to develop image acquisition and processing techniques that would quantify technetium-99m sestamibi tumor uptake in this cohort, and to determine the effect of the molecular subtypes in TNBCs versus other subtypes. As we are familiar, this 99m sestamibi is a radiotracer developed originally as a cardiac imaging agent, but was found to accumulate in cancers, including breast. And this is predicated on the binding of technetium-99m to the mitochondria that increases in lesions with increased angiogenesis. The advent of the new small dual-headed cadmium zinc telluride semiconductors allowed for much more efficient, effective, and high-resolution scanning of the breast that is displayed in a similar format to mammography. So here are a couple of patients that have been participants in the trial. We have a 59-year-old woman with left triple-negative breast cancer, where the final pathology showed complete pathologic response. So we see that we take 3 time points of ultrasound measurements in 3 dimensions, and a formula is used to calculate the volume. And at mid-treatment, there is a more than 80% volumetric decrease, which means that the patient does not go on the non-responder adaptive trial. And at the end of ultrasound treatment, there is no measurable tumor. There is what we see in the bottom right-hand image, just the clip without any residual mass. Likewise, on the MBI study at 3 time points, we see the small focus of uptake in the inferior half of the breast. And as you move along the treatment path, the last study is cold, and this concurs with the pathologic findings. In a different patient who is a 32-year-old woman, also with triple-negative breast cancer receiving neoadjuvant chemotherapy, we see on the left a large tumor that's decreasing in size through the treatment cycle, again with a tumor bed and a clip in situ. However, the correlating MBI shows that there is residual increased uptake, and this was confirmed at surgery as residual disease. So if you notice, both of these images, both sets of images are qualitative and descriptive. So the goal then is to develop a method of quantitation for quantitative analysis using MBI, and this is ongoing work. I think we have accrued 37 patients as of today, and working with our physics collaborator, the goal is to be able to create a measure of quantitation of uptake within the lesion of interest. So this is the formula that has been generated, and ongoing work is looking at both the tumor itself as well as the adjacent breast parenchyma. And here we see it in both views, and I think that the data will be presented at the RSNA this year. But some preliminary results from a small group of patients early on in the year, with 17 patients having completed the study. The quantitative metrics have shown that patients with PCR have a higher baseline SUV compared to patients without PCR, and a larger decrease in the SUV at the first follow-up for patients with PCR. So those are methods that may help in triaging patients as they are being categorized into patients that are eligible for the adaptive trial versus patients who go and carry on with standard of care treatment. So with this early data, the thinking is that while tumor size and tumor volume measurements may not be the most accurate, some form of quantitation using MBI metrics will hold more promise in predicting pathologic complete response. Based on these findings, we are also ready to trigger a multimodality breast imaging protocol for the assessment of tumor response to the TNBC patients. And the goal is to have the patients present for mammography, ultrasound, MBI, and MRI. To date, we've accrued 12 patients out of the 100 patients in this cohort, waiting for the entire series of studies to be done for the entire group. So it's going to be imaging at 3 time points, baseline after anthracycline, which is approximately 6 to 12 weeks, and then at the conclusion of neoadjuvant chemotherapy. So in summary, what I wanted to show is that the triple-negative breast cancer moonshots and all other moonshots are a culmination of tremendous multidisciplinary collaboration, starting with us in the imaging group where we obtain the tissue and the specimens. On top of the diagnostic biopsies, approximately 7 additional core biopsies are collected from these patients who volunteer for the studies that are sequestered for molecular discovery assays, cell line and PDX models assays, and at the 2nd and 3rd time point, an equivalent number of biopsies are performed. So it is a big commitment for the patients, for the clinicians, for the multidisciplinary team to shepherd these patients through, remembering that they also have 4 different modality imaging studies at each time point. Just wanted to do a shout out to our colleagues. On the left is the breast imaging team. To the top of the slides are the breast pathologists. To the right are the clinicians in medical breast oncology, and at the bottom are the surgeons. So this would not have been possible without the entire team working together. The Ovarian Moonshot program was predicated on recent publications by the Jinong group, who are proponents of cytoreduction using laparoscopic assessment as the standard of care. And basically, their goal is to develop a framework for personalized approach to the management of ovarian cancer, frequently at late-stage diseases. So the concept of cytoreduction with laparoscopic assessment follows this workflow chart, where patients with high-grade serous ovarian cancer as a separate moonshot will undergo laparoscopic evaluation as the first point of care. If extensive disease is seen, cytoreduction is performed. After this process, the patient comes for a contrast-enhanced CT follow-up. If the patient has extensive disease and does not undergo cytoreduction, then there is additional chemotherapy followed by imaging for response, and then the cycle goes on. So the scoring is as follows. Score 2 is listed on the left, and the areas of interest that the imager has to pay attention to will be the peritoneal aspect of disease, whether there's carcinomatosis, looking for disease in the subdiaphragmatic areas, the mesentery and the omentum, looking for signs of bowel infiltration, and any liver surface lesions. So score 2 is significantly higher disease than score 0, and an algorithm is shown at the bottom of the slide that is used for staging these patients in a precise model. So those are the 5 areas that have been incorporated into the structured reporting for patients who present on these protocols, specifically diaphragmatic involvement, liver surface involvement, mesenteric involvement, omental involvement, as well as bowel infiltration on the slide to the right. Here is an example of a patient who was deemed to have extensive disease at the beginning and was treated with neoadjuvant therapy and showed good response on the slide to the right. And ongoing imaging protocols that are being developed in terms of supporting the ovarian moonshot is to use PET-MR to assess for cytoreduction, and in the future hyperpolarized carbon-13, and to explore avenues in which this can support the ovarian moonshot. So the goal here, I hope I've been able to share with the group, is that every patient that comes and participates in the moonshot potentially will benefit from research that is a combination of both what is done in the clinic as well as what's done in the wet bench, and combining to form a translational research platform that also relies heavily on computational biology as well as analytics, with one goal of accelerating the translation for cure, improve survival, and decrease mortality for the patients that has traditionally been over decades to a much shorter time frame. Acknowledging all my colleagues in imaging, thoracic medical oncology, breast medical oncology, as well as in imaging. Thank you very much for your attention, and this is Anderson with its mission of one people, one goal in making cancer history. Thank you. Happy to take any questions, I think. Yes?
Who funds all the charges, say, for the imaging?
So,
Who funds the charges, the extra charges for the imaging analytics, for instance, that you showed that all the patients undergo ×3
exactly.
for the beginning, middle, and end?
So that's a great question. So for the last 4 years, our president, Ron DePino, was actually, the prior president was a big proponent of philanthropy for this endeavor, and a whole budget has been allocated to the different moonshot platforms. So they come from a specific moonshot budget line, so it's non-standard of care comes under research charge. Yep.
So you showed some reports with a lot of analytics, and it's like embedded in Epic as well. Do you see in the future our radiology reports being really heavy on the analytics, or are there still going to be some sort of conversational report in there as well?
So our original very ambitious goal when Kayak was developed was that it would start out with the research protocols, but at some point, X years down the line, it was 5 at the beginning. I think that's pretty ambitious. The goal was that every cancer patient that would come to Anderson would have some form of analytics, because our original review showed that 70 to 80% of patients who present for imaging are patients who come for response assessment. So the surveillance, no evidence of disease, is a very small fraction of the patients. So the goal is to have the Kayak report embedded next to the clinical report. The other way to answer your question is that we have made structured reporting a mission for this year, FY18, and even without the analytics, our goal is for different subspecialties to have structured reporting that answers specific questions, either for the surgical group in ovaries, or the surgical group in liver, or the surgical group in pancreas, so that the key elements are documented and will assist with data retrieval. Yeah.
So do you think the Moonshot goal is going to be achieved?
I think that's a wonderful question, and that's been asked many times, whether it's going to be achieved now, 5 years or 10 years. I think the aspiration towards it and the energy around it, for one, gives a lot of hope to patients. And I believe that along the way, a couple of meaningful discoveries will be made. I understand that the couple are almost ready to go into pipeline. So out of this broad platform, 2 of them are almost ready. Yeah. That's not within the purview of the imaging group, though. Yeah.
For the breast imaging, for the molecular breast imaging, I'm just wondering why technetium tracer is being chosen instead of PET tracers like FDG, particular given that the dedicated positron molecular imaging system, breast imaging system are available.
Sure. I think that we were also exploring the dedicated PET systems for the breast, and that was in 2009. It's been very difficult to get that into the mainstream, number one, for patient billing purposes. Number two, the dose from the PET injection is still significantly higher than what we've been able to get away with for the sestamebe. We're currently using 6 millicuries. Hopefully, with time, we are thinking of going lower, but the doses that were being used, even for dedicated PET, was significantly higher. Yeah, in several orders. Okay, thank you. Thank you very much. Thanks.
So Wei, thank you very much. That was great. We have this plaque for appreciation for you coming here.
Thank you.
And I think that not only does your institution serve as an inspiration, but you do as well.
Thank
So
you.
thanks.
Thank you.